Thanks, I'm Bradi Granger, and I am humbled and honored to be here today in front of some of the greatest teachers I've ever had in this space. Ed Hammond and Ricky Bloomfield and Nikolai, our MedApp architect. So, as a nurse, I am excited to be here. I am a professor at the School of Nursing, and then on the clinical side, I run the Duke Nursing Research Program, where we study ways to improve the quality of care delivery and the quality of patient care outcomes. And Katie McMillan, our DHTS expert, is joining me here today. We've had a number of groups support the development of the Duke Pillbox, and they represent sort of three vested key stakeholders: medication industry, the quality industry, and most recently, Duke. So it's nice to be sponsored by the care provider and the home team, so thank you. I'm going to begin with a case, which is how this whole adventure started about 5 or so years ago. This is a common case that we experience, and we set out to find a solution that would help us to address this better. A 64-year-old man presented to us with a history of diabetes and hypertension and hyperlipidemia, and he was complaining of epigastric distress radiating to his neck, 8 out of 10 on a pain scale. And he had recently had several months of increasing angina at rest. He had no prior symptoms of this sort, no nausea, shortness of breath, and he had no prior history of cardiovascular disease. He had not had a stress test or a cath. On presentation, his 12-lead EKG looked like this. So he had serious ST elevation in his anterior leads. And according to the guidelines, he went straight to the cath lab. He got there in less than 90 minutes as our target goal. He received terrific care from Jimmy Chang and team, who has also been a huge supporter of the development of this and has just had to leave to go back to the cath lab, so that's too bad. But he had a great result. And at the end of the case, he had a preserved left ventricular function, which is our goal. And he was discharged on a panel of medications, evidence-based medications for cardiovascular disease, including an antiplatelet agent, a P2Y12 inhibitor. So at this point in the case, we were scoring 100 on our quality measures, and we were ready to get paid and also be proud of the good job that we did for taking care of our patient in accordance with the guidelines, a perfect score all the way down the line. And as many of you may know, the guidelines indicate that after receiving a stent for a case like this, patients are prescribed a P2Y12 inhibitor, which they're supposed to stay on for 1 year. But about 14 days later, our patient came back to us with a 12-lead that looked fairly identical in nature to the first one. He had suffered an in-stent thrombosis, and he had another ST elevation MI that day. So he got another bare metal stent and another hospitalization within the 30-day CMS window. And we proceeded to be disappointed with ourselves for not being able to support him better and for kind of losing the game on quality metrics, as it were, from the hospital perspective. And then in taking care of his family, we also were losing the game. So what is it that you all think? What proportion of patients after discharge, when they have the correct medications and the correct instructions, and the team feels like we've checked every best practice alert in our medical record, what do you think? How many people think 20% of patients do not complete their medication? 40? A couple. 67? 90? It's 67. So about 67% of the time, patients don't follow through with instructions. And there are a lot of key contributors to this, and I personally have studied reasons for medication adherence for the last almost 30 years. So we educate as a healthcare team from a lot of different angles. As nurses, as pharmacists, as physicians, we provide a lot of education, and we've studied education a lot. We've also studied health literacy. We know that in Durham County and in the Southeast in particular, our average health literacy rate is 33% of patients don't score above a third grade level on a standard health literacy test. And this issue of communication keeps rising to the top because it's not usually cost, because the same statistics bear out when we study patients at the VA, for example, where all meds are free, and when we study them in Sweden, where all meds are free. So cost is not usually the factor, and when we address other issues to overcome health literacy and educational issues, we still have the same kinds of statistics. So the quality metrics that we're held responsible for in this country, and then increasingly at an international level, include that medication reconciliation be done at discharge, so we did that. They include that we provide skill-based patient education where we require a teach-back exercise from the patient. We did that. We have communication metrics for quality of care at discharge. And then we have patient engagement metrics at discharge. And these are the two that seemed like an opportunity for us. And so that is the beginning of how we embarked on this app, in trying to figure out why our standard guidelines for care, which get translated from clinical trials into best practice alerts and other clinical practice routines, why they don't hold up. And this is part of the reason, which has been discussed by almost everybody today, and that's that it's hard to stay engaged with patients after they leave the hospital because they go all kinds of places. And so even though I feel like we're really lucky to have Epic integrated across all of our Duke Health systems, including our federally qualified healthcare center downtown, we still have a gap in many of these places. So our dialysis clinics are not all connected. Patient homes are not all connected. Some of our skilled nursing facilities are not running Epic, and the pharmacies have trouble. We have also got a number of local community support programs where we do community-based care in a number of ways to address education and health literacy and understanding of a medication regimen, but then the work that gets done there is difficult to get it back into the Epic system. One last piece of data before Katie explains the solution to all of our problems is this. This was done by our colleagues in Europe at the European Society for Patient Compliance and Adherence, where we work together to look at adherence around the globe. And this was a meta-analysis of interventions for medication adherence. And the big lesson that came from this was the idea that if we could give feedback to patients on their actual medication use that was delivered in a way continuously available to providers as well as family members, we would be able to change behavior 20%, which is greater than any other intervention done so far. So our goal was to provide bidirectional communication to patients in an ongoing way about their medicines.
Thanks, Brady. So Brady's been working on the Pillbox for a few years now, and the initial implementation of it was done actually at the hospital, where a pharmacist sat down with the patient. They showed them what you're going to see, what the application looks like with their medications, have them drag and drop those into the right time of day that they're supposed to take it, and make sure that they have an understanding of what each of those medications are. In the last year, she was funded by the Duke Institute for Health Innovation to move this to more of a patient-facing application, which is what I've been involved with her. So there's kind of 3 steps to how we're doing this. The first part is that we have a human touch. So a pharmacist calls the patient. And for this project specifically, we're looking at diabetes and hypertension patients. And they call them and they go over their list of medications and they say, you're on these 10 drugs. Are you familiar with them? Do you have them? Do you know when you're supposed to take them, and kind of answer those initial questions. And then we say, are you interested in this digital tool where you can go in and actually track your use of your medications, so we can see if those are actually helping you, because that's one of the big issues with medication adherence is if patients aren't actually taking the drugs, you don't know if they're really helping them. So this gives a little insight into the clinicians as well with how what they're prescribing is actually doing for their patients. So we set up a connection between Epic, that the providers are using, and MyChart, which is the patient portal for Epic. They're able to go in, open a patient note. All they do is put in .pillbox as a smart phrase, and that automatically adds the Pillbox link into the MyChart, so then it's activated where the patient goes to see all of their other medical information. Then they're able to log into MyChart, access the Pillbox, and use the tool. So I have a little video, and I can just kind of walk you guys through how this all works. So this is what the online patient portal looks like. You go in and put their normal username and password in, sign in, and then you go under My Medical Record, and it shows up that the Pillbox is there, so they can launch it from within MyChart. And then this is the application that they see. So they get a little, welcome, saying it's an interactive tool. And then they see all the medications that they're taking on the right-hand side, and they can drag and drop it into the different time boxes that they should be taking those meds. And then once they're done, they can hit check, and you can see, oh, they didn't really know what they were doing. So, let's get a hint. So you can click on here and get a hint, and it'll actually move the meds into the right boxes, so you can see, okay, this is what I'm supposed to be doing. You can clear it out, which you can see on the right-hand side over here, and start over again. And they can do this, every day, as many times a day as they want, and we can collect data on their actual usage of the application. So digging into a little bit more of the technical stuff about how we do this. So as you can see, the patient launches the Pillbox app from MyChart. It communicates with the authorization servers, so that's how it knows that you are actually a Duke patient. You have a MyChart account, and grabs those FHIR resources, authenticates the app through MyChart, goes to Dash, which is our API manager, and then goes through to the EHR, grabs the information, sends it back into the back end, and then the patient sees that. So if you're interested in how we built this, and I don't know if the slides are getting posted somewhere later, but we really only use 2 FHIR resources to make this happen. We use the medication FHIR resource and the patient FHIR resource. So I just put in the links there to go into the details if you're interested in more about that. And that's the Duke Pillbox.